various topics that you will see as the discussion goes on. And then we will hopefully have a question and answer session and a discussion at the end. So I'd like to just ask the IT team, could you just start the presentation? Asante. Thank you very much. So by way of setting a background, Sanofi is a pharmaceutical company that has a specialized social business unit called the Sanofi Global Health Unit. And we have a unique business model that aims to strengthen healthcare systems along 3 pillars. Now, the presentations that you will see today are a testament of what we have been doing in the last 2 years to be able to integrate partnerships to strengthen healthcare systems in Tanzania, all right? So my duty today is actually to introduce the panelists who I will ask to just come up front. So the first speaker that we'll have will speak around what the Tanzania Diabetes Association is doing together with the Ministry of Health in improving healthcare. I'd like to invite Dr. Rachel Dumu to just come and sit at the front. You can give her a round of applause as she comes. Thank you. Then our second speaker is Patrick Moendorf, who is affiliated to Touch Health, and he's going to talk about the MedFikia program, which aims at quality improvement at the point of care at the pharmacy level. Please, Patrick, come to the front. And then we'll have a third speaker who is affiliated to PharmAccess, and that's Faiza Abbas, who's a program manager, and she's going to talk about what we are doing together by way of strengthening remote management of NCDs through patient groups. Faiza, could you please come to the front? Then our fourth and final speaker is a very wonderful gentleman called Joseph, same name as myself, who is the CEO of Dawam Kononi, and he's going to talk to us about data-driven decision-making for health systems strengthening, and he's coming right from the back. All right, so ladies and gentlemen, without wasting much more time, I'll invite each of the speakers for 5 to 10 minutes to just run through some of the key learnings that you have seen by way of implementing health systems strengthening projects in Tanzania. And then I'd like to ask you to just park all your questions to the very end, and then we'll be able to have a wonderful discussion. Thank you very much. So first we'll start with Dr. Rachel Ndumu. Welcome.
Good afternoon, everyone. Welcome to Sanofi Forum, and I'm Dr. Rachel Nungu, a program manager from TDA, Tanzania Diabetes Association, and I'm going to take you through strengthening NCD care in Tanzania, our collaboration as TDA with Ministry of Health and PRI in strengthening NCD care in Tanzania. As to start, we all know that the burden of NCD has been rising in the past years, and it is contributing to 41 million deaths that occurs globally. That is death, like 17 million premature death. That means people die before reaching the age of 70, and 85% of this premature death occurs in low and middle income countries. And in Tanzania, NCD contributes 34% of all mortalities, and 31% of these mortalities are premature death. And this has been a concern, the national concern, because the incidence of NCDs have doubled in the past 2 decades. And in the era where we face a a challenge of having like a double burden of communicable and non-communicable diseases, and also have overstrained healthcare systems in our country and disparity in the availability of NCD services in all levels of facilities in Tanzania. But globally, as we know, in the Sustainable Development Goals, they have added NCDs among the goals due to its alarming increase. And in the Sustainable Development Goal number 3, we aim at reducing the premature mortality by 1/3 by 2030, but also we aim at achieving universal health coverage and increasing health financing and equipment and training and retention of healthcare providers who can provide NCD services at the facilities. In line with this, the Tanzania Diabetes Association, which was formed almost 40 years ago, with people who are concerned firstly with diabetes and who joined hands to ensure that there's availability of services for diabetes patients in the past, that means availability of equipment, medications for diabetes, see that NCDs does not only include diabetes, it is included to include other major diseases such as cardiovascular diseases, respiratory diseases, and cancers, which are also having major impact in our country. Therefore, it is in order to ensure the availability of prevention and treatment of NCDs and in health system strengthening, TDA has been collaborating with Ministry of Health and PRH in the past 10 years to ensure that we promote NCD services or programs in the country. And to start in the 2012, TDA, through the National NCD Program, in collaboration with Ministry of Health and PRH, we decided that we need to have trainings and building capacity of healthcare providers at all levels. So in these years, from 2012 to 2018, we decided to focus in the national, zonal, and district and regional hospitals. So within these years, we end up training approximately 2,548 healthcare providers at these levels. And also we provided equipment, we provided eye and foot equipment to the zonal and regional hospitals. But also we ensure that these trained facilities, they have NCD screening kits that include glucometers, stethoscope, BP machine, and the like, so they can do screening of people who are visiting these facilities. And this increased the number of NCD services that are available at the national and zonal and district hospitals. And this also was in line with the NCD Strategic Plan 2016 and 2020 that was implemented at the time with the Ministry of Health. That also was to promote prevention and treatment of NCD care at these levels. But going forward, when the Ministry of Health was developing a new strategic plan, 2021-2026, that is currently being implemented, TDA saw that there's a need to go down to all our facilities in providing these services. Because initially we started with the national and zone, as I've explained before, but then we know that the patients or the clients are coming from the grassroots. They're coming from the community. So in collaboration with the Ministry of Health and PRH, we led to the formation of the National NCD Prevention and Control Program under the Ministry of Health. This is the NCD unit, which is under the Ministry of Health, which is also being supporting implementation of the NCD Strategic Plan. And you've been collaborating with them since 2019 in this new program. And so far, we have been able to go to the health centers to provide training to healthcare providers at the health centers, whereby by 2023, we've trained 710 health centers, whereby 2,880 healthcare providers were given basic training on NCDs. And these healthcare providers were also trained on how to prevent and manage NCDs at their level, at the primary center, and were given also essential tools such as glucometers and test strips, BP machine, cervical examination tray, monofilaments, peak flowmeters, and the like, so they can offer these services at the primary level. So you can see how the TDA has stepped down, like from the national level to district and the regional. Now they have gone to the primary level to ensure that there's availability of NCD services at the primary levels. Apart from that, other achievements that we have as in implementation in ensuring we have NCD care in Tanzania in collaboration with Ministry of Health and PRH. We have other programs such as National Type 1 Diabetes, as we know that there are children and youth and adolescents who are suffering from type 1 diabetes, which has no cure, as it's a chronic illness. And TDA has been, for years, has been trying to ensure they have access to treatment, including availability of insulin in the country. And we have been increasing our clinics where we ensure they have access to care. We used to have 33 healthcare facilities since 2005, but in collaboration with Ministry of Health and PRH, we have managed to reach to 83 type 1 diabetes clinics at zonal, regional, and districts, and we have been serving more than 6,000 children and youth in these centers. So these centers, they usually provide care that include education, counseling to these children who are born with type 1, and also give them free insulin that will be donated by TDA. And we have been distributing HbA1c machine, which are used to measure the control of diabetes to these children. And by last year, we managed to distribute 73 HbA1c machines to 73 health centers, health facilities that include 41 in the mainland and 32 in Zanzibar, because this type 1 program is in the mainland and is in Zanzibar as well. We also have National Food Program, which has the objective of reducing amputation due to diabetes mellitus. And we are equipping healthcare providers with knowledge on diabetes and prevention, but also how they can screen their food so that they can save these limbs for people who are having diabetes. And so far, we've managed to train 51 facilities, whereby we train TOTs who can go back now to their facilities and train other doctors, surgeons, and those people who are seeing these patients with diabetes. And we also provided essential diagnostic and foot care tools, which include tuning fork, patella hammer, monofilaments, and dressing trays, so that they can see these patients and screen them for foot ulcers. And this training was done in 2022. By 2023, when we did a 1-year follow-up, we noted that 14% of people who were screened for diabetes foot had foot ulcers, and 61 out of them, they had their foot were infected, the ulcers were infected. And with these trained personnel, ended up healing the 37% of these infected ulcers, so that they prevented amputation to these 37%. And also 25% ended up with amputation. But this was a decrease from 28%, that was our baseline. So we still have a long walk to go, but this has been an achievement to us, so that we know now people have been trained on how to save limbs due to diabetes. We also have been trying to strengthening the health information system together with the Ministry of Health and PRH, whereby we have another program called Diabetes Compass, which is the aim at integrating using digitalization in improving and strengthening the diabetes care in Tanzania. So what we have been doing so far, we have managed to introduce the NCD micromodule in the centralized gotomies that is under PRH, whereby now any healthcare provider who have access to centralized gotomies can click on these NCD micromodules, and all patients' files, all patients' information have been collected here. So now we ensure that the patient data are not lost, and there's track and follow-up of this patient to ensure good outcome of these diabetes and hypertension patients. And together with the PRH, this has been a success using the PRH ICT system. And so far, more than 2,000 health facilities, they have these centralized gotomies across the country. And we are sure that they have these NCD modules under them. And we welcome other stakeholders who wants to put other NCD modules, apart from diabetes and hypertension. They can put them in these NCD micromodules to ensure there's uniformity in data collection. So what are the challenges and lessons that you have learned so far in this collaboration with Ministry of Health and PRH? There's ongoing challenges in resource limitations, such as present availability of healthcare providers. As you know, the ratio doctor and patient or healthcare providers ratio have never been reached. So sometimes you need to have continuous training so that you have more competent doctors who can treat, and nurses who can treat and manage NCDs. But also the NCD requires multi-sector approach. Now we are collaborating with Ministry of Health and PRH, but it's a multi-sectoral it needs a sectoral partnership. We need to involve other ministries, such as Ministry of Land, Ministry of Sports, and the likes, who are having the mandates in some of the policies that can guide us in NCD prevention. So this has been a challenge because we need to come up with proper strategies together with all these stakeholders so that we can have proper outcome of NCD's prevention and reach the sustainable development goals. But also maintaining the NCD services at facilities require ongoing training, as there is a huge staff attrition. You may be training staff today, but in 1 year they've been moved to another departments, they've moved to another facilities, they've even gone for their advanced education. So this makes the NCD services to suffer a bit at these facilities. But also we need community level interventions that are critical to prevention and management, because now we have been focusing in building capacity at the facilities. Now we need to go to the root, we need to go to the community. We need to educate them on how to do prevention and how they can even do self-management, or they can care themselves for the NCDs. So our future steps in management of NCD, we want to emphasize on quality of care, as has been discussed in the previous forum. We need to ensure we have quality of care. Having access to the health care, to the services is not enough if the quality is not good. We need to have good outcome to these NCDs conditions, which they usually have complications if they're not managed well. But also need to have continuous training. So since we know that physical training, they are usually costful, it needs a lot of investment in having physical education. We need to incorporate them with the online trainings and CMEs at facilities. So the government, through the CMEs, they can emphasize on putting more CMEs on NCDs, but also having the HMIS system integrated with the client journey from the root, from the community. We don't have to wait until they come to the facility for you to start tracking their journey. We need to start from the community. When you have community workers, healthcare workers who have been interacting with these patients, so that the prevention and management needs to start at the community with the improved HMIS system. But also the community engagement, which is also a good component, as I mentioned before, through the community healthcare workers. We need to put more emphasis on them who have interaction with the community. They know how the families are, they know their condition, they know their economic status. So this way they can engage with them easily. And so far we thank Sanofi. We have a new project with them that is coming up, where we'll be emphasizing on NCD prevention and management through the use of CHWs, and see how that will enable us to improve the NCD prevention and management. But also there's a need of continuous monitoring and evaluation. These you have seen, they are all things that we have done, but we need to see what are outcomes out of this. We need to continue doing the monitoring and evaluation in mentorship at the facilities which we have trained to see the viability of these services, but also need to do operational research or implementation research, as it was discussed in yesterday's meeting, that we need to ensure that this strategy that you are putting in place, these guidelines, what are the outcomes? Are they working at these facilities? But lastly, we need to ensure there's integration of services. Chronic diseases are chronic diseases, be it HIV, be it diabetes, be it TB. So there's a need to integrate these services. The clients are the same. We don't discriminate the patient. You're having HIV and you're having TB. They all need to have coordinated management, coordinated treatment at the facilities which they are attending. So to say this, I would like to thank everyone, and also use this opportunity to call upon the continuous collaboration between MOH, PRH, and all stakeholders who are to be involved in NCD's prevention. Thank you so much.
Thank you very much for the introduction, Joseph. My name is Patrick Mondorf. I'm from THS. Sorry. Now it's better, probably. Thank you, Joseph. So again, my name is Patrick Mondorf. I'm the project manager for Touch Health for the Medificia program. And what I would like to introduce you to today is the Medificia program, a holistic approach to transform the NCD care across Tanzanian landscape. So the first question is, how can we design and really implement a holistic approach if we do not understand the landscape? So the first thing that we had to do is really know what kind of issues we do have with NCD, because as Dr. Rachel said before, the NCD burden is growing and keeps on growing. This is also something that we understand. So what do we need to do is to understand where the gaps are. What we want to do is address them. So during our analysis, what we really learned is that we can mainly build a two-pillar program across those critical gaps that we identified. On one side, on the patient management part, on the other side, on the supply chain and operational excellence part within the pharmacies at a primary healthcare level. What it means is what we really identified is a massive lack of capabilities in terms of patient tracking. I think you all probably know it even more than I do, but NCD patients do need close monitoring. This is not a condition that you will be able to resolve after going to the pharmacy once, getting medication once, and then you never come back. This is not how NCDs work. So you need very close monitoring. You need a constant evaluation of your situation, and if your vitals are improving or decreasing in terms of health. So this is why the lack of patient tracking and patient management skills is something that we need to address critically. The other parts are unstructured services from healthcare center. So what we understood in our facilities is that some NCD patients are actually being treated as OPD patients. They do not have a regular clinic. They do not have regular clinic days. So this is a big issue because some of those facilities will just be lost in the system. They will not even be recognized as NCD patients. So what we need to do is improve monitoring skills, is improve like the overall tracking and management of those patients. On the other side, not only from a facilities perspective, but also from a patient's perspective, patients need to be informed. The lack of education sometimes regarding NCD diseases, non-communicable diseases, is very big and therefore also decreases the retention rates that facilities can achieve. So those are all issues that we need to address on the patient side and on a, let's say, patient work stream. On the other side, as I already hinted, we do have two pillars in our program. The other pillar is the medicine management. This is more like a supply chain part where we actually want to address as an overarching goal the medication availability, because this is one of the big issues we encountered and understood. One of the core challenges is really the medication availability for patients in need. So the inefficiency in pharmacy processes may be there is no first in, first out method, so meaning there's like a lot of medication going to waste. Stock management issues in terms of stock accuracy. Some facilities don't even know what kind of medication they still have in the back of their shelves. So those are all issues that we need to address with simple methods, which gain in complexity along that overall process. One of the biggest issues that we found in pharmacies is the forecasting, meaning pharmacies do not have functioning forecasting methods to really adjust their needs to this growing NCD burden, which has already been mentioned like a few times. So this is something that we really need to address, and this is the critical gaps that we identified and the core challenges within our program. I already hinted at that two-pillar structure that we have in the program. So how we actually, and what we want to achieve across the Medificia program is to involve patients in the healthcare journey, is to get a higher retention rate through informed patients. If a patient knows that, oh, I need to go in twice or 3 or 4 times, and it's not only a one-time disease, then he will come back to those facilities. So we want to achieve informed patients through different kinds of interventions that will make sure that the retention rate grows. What we want to have is the possibility to treat patients as needed, meaning if they come into the facility, we want to be able to give them the medication that they have, or like provide them, like make the facility provide them with a medication that they need. So the big question is, how can we achieve it? And this is something that we really address in our holistic approach. I just brought a few key interventions here that I would like to show you how we address those critical gaps. On one side, we have, once again, I'll always stick to the structure that we have in the program, meaning based on the two pillars. So on one side, we have the patient side, where we introduced patient-held medical records. This is a simple, let's say, very simple piece of paper, which actually adds a lot of complexity by tracking all relevant clinical histories, the risk factors that a patient might have. It provides a treatment plan to the patient, which the patient brings at every visit to this facility. So through recording and providing a treatment plan, it's on one side involving the patient in this journey. He will be able to go through each visit, through each vital that has been recorded at each visit, to really understand, oh, okay, my vitals are improving. Now I'm going in regularly, so my vitals are actually getting better. So what this patient-held medical record does is really closing the gap on one side to involve the patient in this journey, on the other side to provide the facility with an overview of everything that has been done in terms of past treatments. And one of the biggest issues is it closes also the gap in referral processes. Because if a patient has been referred to a district hospital or to a higher-level facilities, up until now they maybe received feedback by phone from the lower level facilities, but there was no real treatment, no information about what has been done over those past months. So now with this piece of paper that the patient can bring into the higher level facility, they will be able to see exactly what has been done, which medication has been prescribed, and if the patient adhered to the schedule, because the scheduling information is also on this piece of paper. The other solutions that we provide is a digital prototype with scheduling functions for NCD patients to really start tracking patients, to allow facilities to understand how many patients do not adhere to the schedule and to long-term contact them. On a pharmacy side, we do implement operational excellence processes, meaning what we are trying to do is really make the facilities understand that workplace excellence and operational excellence is crucial. Simple industry-proven processes such as the 5S principle, visual management boards, tracking of KPI, and the introduction of KPIs, those are all things that we are trying to implement and therefore have as a solution to improve to lessen the burden of NCDs with improving those facilities. Now, I know that I just talked a lot about how we did it, but what I also want to show you is that it works. So the Medificia program, I brought some key successes and a few key KPI, and I have to add a little comment. At the point of creating this presentation, there was 8 facilities enrolled. Right now, the Medificia program scaled up to 20 facilities already. So right now, the 1,500 NCD patients enrolled in the PHMR card process, which I just described, grew to 2,000. But overall, across the 8 facilities in Monza, even at that point 2 months ago, we achieved a 20% increase in recurring patients. We doubled the NCD medication availability in those facilities, and we reduced the stock out occurrences by 80%. In terms of, and those are things that really, as you can see, those are big numbers. There was a lot of room for improvements with those kinds of interventions. We also introduced surveys towards the facilities, because what we want to do is keep on improving. We want to keep learning how we can help them best. So with those NCD surveys, we actually learned that over 90% of the staff in those facilities we're in does agree that through our interventions, they can provide better healthcare services. No, sorry. So, as I said, the key indicators show that we do manage to reduce stockouts, that we are able to help in retaining patients in those facilities. So what we want to do is, of course, replicate its success. Again, at the point of creating this presentation, we were focused on Mwanza. Right now, we already implemented in 12 facilities in Gator and just came back from an assessment in Kagera to also implement and enroll facilities in the Kagera region. This is also happening by a phased rollout approach because, of course, with the hands-on approach that we have, which is one of the key elements of the Medifikia program, because we're not going in, giving them some stuff and going out. But what we want to do is really mentor them, really be there for them and support them through supportive supervision sessions. So this is why we have a phased rollout approach in which we take on a subset of facilities at a point of time and increase those facilities going forward. As I already hinted, so we want to expand to over 30 more facilities, adding up to a total of up to 38 facilities as of now, and really focus on improving those facilities continuously. Of course, we also face challenges. Those challenges specifically in terms of the digital prototype that I mentioned, we need hardware, we need all the equipment, and we also need the knowledge to be transferred towards the facility staff to really be able to execute those processes correctly. So, of course, we're not at a perfect state yet, but we are definitely making the improvements by supporting those facilities with those interventions. So in my opinion, and I know that I'm a little bit biased, but Medifikia is making a transformative impact across the NCD landscape. And at this point, I really want to thank our, let's say, partners, of course, with Sanofi, but also the collaboration that is needed to really achieve those goals on a long term, meaning also the Paralgia Ministry of Health and also having the district and regional level stakeholders, such as NCD coordinators and medical officers, being involved in our program and making the difference for us to relieve the burden of those NCDs. Thank you very much.
Good afternoon, everyone. My name is Faiza Bass, working with Farm Access. Before I start my presentation, I would like to highlight some of the key issues that I'm pretty sure you might be aware of. But reflecting the two previous speakers who spoke about the NCD global burden, I want to focus much more in the African context. As we all know that in numerous African nations, the pursuit of universal healthcare coverages faces many challenges. Simultaneously, NCDs are emerging as significant health issue. As these nations struggle with limited resources and infrastructure, innovation approaches for healthcare become imperative for realizing the universal healthcare coverage. So Farm Access' unique value is to create transformative innovations that can be replicated and duplicated by others. So in this presentation, we are going to share how we have transformed NCD care through community-centric approach, through a community-centric digital approach. This model did not only strengthen our health system, but fostered integrated partnership, which is very important in sustaining long-term impact. Let's reimagine what's possible when technology meets with community-driven care. I hope after this presentation you will see how this solution can be scaled up, not only in Zanzibar, but in other similar settings to create a future where healthcare is truly accessible to all. In terms of NCD's burden in Zanzibar, just like many African countries, the NCDs is one of the primary causes of morbidity and mortality, contributing to significant high burden to healthcare services in Zanzibar. And if we look on the previous survey, STEP, what was conducted in 2011, we know that the previous survey, last year we had another STEP survey, but still we don't have the result out. But looking on the survey that was conducted in 2011, we see the prevalence for Zanzibar among the hypertension was 33.5, and with among the diabetes was 4.4. Another challenge that also comes with the NCD burden is the poor control of blood pressure and diabetes, of which in this survey it indicated that of those who are already on treatment, only 10% of hypertensive patients had their controlled blood pressure, and only 11.9% of diabetes patients had their blood glucose measurement control. So apart from the NCD burden itself, we see like even the adherence and control of the patients who are on medication is also a challenge. Coming to the challenges that are related to service delivery, we see various challenges in our health system, and these challenges contribute to high opportunity cost to patients due to long travel time to health facilities. In Zanzibar, I think we have only 60 health facilities that are providing NCD services among more than 100 healthcare facilities. So not all health facilities are providing NCD services. There are certain selected facilities that are providing NCD services that creates many patients to have to travel long distance to seek for the NCD services. But the way these services are being provided, sometimes we have the outreach being conducted at the community level, and whereby once these patients are being screened and identified having either hypertension or diabetes, they have to be referred to the next level facility, and sometimes if at the certain facility or at the primary level facility, they present with some complication, they have also to be referred to the next level. So the complexity and all other challenges really create opportunity cost and financial stunting to patients. And we also see in terms of service delivery, the health facilities are overcrowded by patients, minimizing the doctor time in providing services that also compromise the quality of services that is being provided. So together with our partners, Sanofi, who provided financial support, we managed to establish a remote care model with a solution through establishment of patient groups. So we have developed patient groups in the community, and the key component in this solution is the digital. And the key component in this solution is the digital remote care platform. So what we are doing, we are gathering patients who have good adherence from the health facility. After gathering this patient, we talk with them and we provide information on the availability of services in the community, and themselves agree like where they would like to meet up next time in receiving like community services. And the nurse and community healthcare providers are the ones who are managing these patient groups in the community, but they use the digital platform to enter information or patient measurement that can remotely be monitored by a clinician at the facility. So any patient who shows abnormal measurement or needs doctor's attention, a clinician remotely will be able to call a patient and request him or her to go back to the health facility. So with this bundle, remote care, what we are doing, we are providing health education, but we are doing measurement, blood pressure and blood glucose measurement. We are doing medication dispensing and also teleconsultation. And what we expect from these patient groups is to address some of the challenges that I highlighted previously. The successful implementation of this project were mainly contributed by effective collaboration and joint efforts with different stakeholders, including the Ministry of Health, District Health Management Team, community health worker, healthcare providers, and community leaders. So there were a lot of involvement of different stakeholders that made this project successful. As you can see, this intervention needs collaboration from the high level to the lowest community level. But we have gone through different steps to make sure that this project is being sustained within the Ministry of Health. And some of the intervention that we did is development of guidelines so that someone at the Ministry of Health or at the District Health Management team can have a guidance on how they can establish this patient group even when the project ends. But we also have developed the standard operating procedure for community health workers who are responsible to provide health education in the community. And we have also conducted a feasibility assessment together with the Zanzibar University to see how this project is feasible and the perception from the patient and client perspective. But currently through the remote monitoring, we are involving the call center from the health promotion unit of the Ministry of Health. They are the ones who are doing the remote monitoring. So this model has been built in a sustainable mechanism to ensure that it is well integrated within the Ministry of Health system. Oh, sorry. Oh, sorry. Oh, what is happening? Like it's going. Sorry, like. Okay. We have been able to monitor some. Sorry, I think my hand is moving so fast, so the slides are really moving fast. Oh, my goodness. Oh. Yes, so in terms of health outcomes, what we've been able to see is we have seen the improved health outcomes, and through this platform we managed to monitor the patient outcomes into the cohorts. We have all the patients like historical data, and we monitor the progress at each visit. For example, in terms of hypertension, at baseline we had only 11% of all patients with a controlled measurement, but a year after, like recently, we have seen like a percent of patients with controlled hypertension have increased to 22%, and those with diabetes has increased to 52%. What are some of the insights we have seen from this project? Lack of next of kin during the provision of services acts as a limitation towards adherence. Majority of the patients who are coming to this group, they are old age, and sometimes when you provide them with a health education diet, they find it difficult to adhere to because of their, like, majority of the household activities are either controlled by other member of the household. But we also noticed there is low male involvement in the patient groups. Only of all patient groups, who are all members who are 968, only 24% of these are male. But other important lesson that we can take from this project is cultural context, which is very critical when you are thinking of establishing this such a project, because sometimes you have to reflect on the context, issues of gender when you bring together people. So we had several learnings, but advocacy and empowering patients is one of the key issues that also helped to successful project implementation. Some of the achievements that we have seen so far is the successful implementation of this community-based remote care. As I've mentioned in the previous slide, we started only with 3 groups, but currently we have we have 25 groups, but we are expecting also to expand to 11 more groups, so we are going to have 36 groups, both in Unguja and Pemba. But we have also seen an improved health outcome, and we have seen patient engagement at different level because they are receiving care close to the community. They've created a close collaboration with the community healthcare workers. So we have established a system whereby patients are highly engaged to make sure that they are improving their own health. Our future direction, like what's our plans, is to expand reach. We now have 36 groups, but we see the demand, and we have seen like majority of patients are still asking for these groups at their locality. So in terms of demand, there's still high demand from the patient. And in terms of building capacity, we feel like for this intervention to be sustained, there still need to be capacity building ongoing at different level, at district and to healthcare providers at the facility level. But integration of new tools is still critical. We have seen like currently there are different digital tools that can connect patients. So we feel like in the future there's still need of having these digital tools to accelerate or provide more quality services. And we think advocating for policy integration can increase public awareness to support long-term success. And I think most of you were there yesterday during the launch, where during the opening ceremony, we also launched a documentary of our patient group. That is also one of the advocacy, and we're really making sure that we're engaging the ministry so that this integration can be sustained. Yeah, I think that's, yeah, thank you.
Don't worry, lunch is almost at the corner, so I need your energy. When we were in the university, our lecturers used to catch our attention for presentation by telling us, kutakuwa na quiz after the, so be prepared, because there is a quiz. Yeah. I will stand here for the ones who are, and I am the CEO and the co-founder of this company called Dawa Mkononi. I receive, thank you. And I wanted to present to you, old habits that I had. When we were in the ward, we used to tell doctors, I want to present to you this patient, blah, blah, blah. So anyways, I'm going to present something very exciting about the future of technology. And I think this is something that the current health facilities should adopt and should practice. So imagine maybe you're in the village somewhere. Maybe that is where some of us came from on the practice side. And there's a dispensary several kilometers away, and it has understocked medicines in the shelf. That means some patients can't be serviced properly. And we also have issues with counterfeit medicines. Maybe some of their products are substandard due to storage, due to transport. And at the same time, we have issues of lack of capital. These are among the most common issues happening in a developed country, because people, of course, cannot afford. In a very common developed country, you would find actually all of these in one health facility. When we used to do our field somewhere in the Pwani region, even during medical school, you'd find a health facility missing very common things. It could be gloves. And just a kilometer away, you find another health facility with plenty of gloves, but maybe no cannulas. And the other one has plenty of cannulas. So we have these issues happening very often. And due to lack of proper systems of inventory management, so much expiries happen. And if you get expiries, this is revenue lost for a health facility. It's money lost, basically. And at the end of the day, these people also cannot afford to stock so many things. You'd find a health center has the demand. There are people having hypertension and diabetes, but they can't afford such clinics because money is not enough. So these are common issues we would like to address, and how innovation can help to solve them. So this is where we step in. Dawa Mkononi, innovation, and any other company practicing data-driven approaches. The first thing is around credit scoring. Credit scoring, you can imagine it as a place where you can send all your data for the customer behavior, how they buy these products, how they make transactions with their suppliers, and at the end of the day, they get a scoring if they are good pairs or they are not good pairs. Banks have a huge balance sheet of lending, and that is their business. So how can we make banks have the ability to lend health facilities anywhere in the country? We need to integrate credit scoring systems into all the health facilities so that if they're in shortage of medicines, they can get quick loans. And this is something that we do in our company. We make sure that all our client base, depending on their ability to buy and to sell, they can get servicing from banks. The second thing is the hype happening globally all over the world, AI. Almost everyone has heard about artificial intelligence, right? Anyone who hasn't? Okay, I don't see a hand. So AI is truly the future of tech. The ability of gathering health facility data, putting it in advanced technology, is what will make the supply chain streamlined. I don't know if there's anything else that can do that. Because if we have a certain facility hundreds of kilometers away, and you can accurately predict in 3 months what their requirements will be like, that is the most awesome thing. And it's going to really cut off a lot of understocking and overstocking. And the last thing is access and availability. And this is something we are quite proud of in our company. We make it very easy for health facilities to buy medicines. You know, everybody here knows the Kariakoo market is the largest pharma market, right? And in order to get medicines there, you somehow have to make it there. If you're not in Dar es Salaam, it's quite cumbersome. So what people normally do, maybe you travel in your mwendokasi, you know how difficult that is. To just, get into the mwendokasi, you get into Kariakoo, you have to go shop by shop because even the suppliers do not have data-driven systems. You send your orders, it will take you a couple of hours, you get your 3 big boxes. How do you transport those boxes back to your facility? If you couldn't even stand properly in the Wendokasi, how are you going to put the boxes? This is how the boxes, medicines break, cold chain products will stay in the heat area for a long time. So we make it easy. We make it, through your mobile phone, you can just order the products and we'll deliver to you within 3 to 4 hours max. So we also encourage health facilities to practice such kind of technological advancements. And what are the impacts and outcomes that we have created at Dar Mkononi? And we believe the first and foremost supply to the low-income community. These are majority of the Tanzanians, Maybe most of us live in Dar es Salaam, so we get to forget that most of the Tanzanians are actually low income. And if we can make their supply chain streamlined, we are going to save plenty of lives in the country. And the second thing, financial inclusion. Access to capital is a nightmare. If you can help a facility have access to that capital and grow their business, this is going to be an amazing thing, to be honest. Job creation through advancement of technology and economic growth, eventually you get to hire more people. For instance, in Dar Mkononi, we currently have about 100 employees, and we keep on growing more and more year over year. And reducing stockouts and reducing counterfeit medicines. I haven't touched much on the counterfeit medicines, but we do have technologies that can track the batch number based on the TMDA registration and use that to track all the way. And also in case you need to recall a product, you can easily recall. These are technologies that are very important, provided there are still going to be deaths year after year because of counterfeit products in the country. So this is a little bit story about us. We started 2 years ago, and currently we service close to 2,500 health facilities. These range from pharmacies, clinics, hospitals, and just a B2B model. And since last year, we have made over $7.5 million in revenue, and we do have quite a good support from some institutional investors, ranging from angel networks to global corporates such as Sanofi themselves. And we also have support of the Bill and Melinda Gates, German Development Bank, IDRC, and the like. Such players are looking for other players in this market who are willing to take data into the next level. They are willing to fund, and they are willing to see our economies grow through such systems. So to wrap this up, this is only a recap. We only focus on data and innovation, and we believe if we have improved cash flow, the economies will grow. We have seen some of our clients open the second shop, the third shop, the fourth shop, etc. And if we have more financing options, again, that is how banks make their money, but that is also how our client base can grow their skills. So this is our awesome warehouse team, and we also welcome stakeholders, if you're in the audience, who believe that we can work together to revolutionize our health sector. So thank you.
Another round of applause to our speakers. Thank you very much. Joseph and Tim, I'd like you to kindly come to the front. We will now go into a brief question and answer session. Yes, please. Just come so that. Excellent. So I believe the audience has been able to see what we meant by trying to strengthen health systems through integrated partnerships. As I had mentioned in the introduction, all these organizations that are working here in Tanzania that are doing various things, and if you listen to the conversations that they had and the presentations, you'd realize that there is something that is being done to strengthen the capacity of healthcare practitioners to be able to manage patients well. There is something that is being done in the ecosystem or the infrastructure, supply chain, and etc. I believe Patrick talked about that. There is also something that is being done directly to help patients to be able to live positively with their condition and to be able to access care, as was described by Farm Access, the patient groups. And obviously, technology never misses in this kind of conversation. So that is the picture. That is the whole integration element that we were talking about. Now, quickly, I just want to check, is there any question in the audience? And we'll give equal opportunity to both men and women, as opposed to the previous conversation. So yes, you'll just quickly shout your name, and then you will address the question to the specific individual, and then we'll go. So we'll take the first four. Yes, sir. Do we have a roaming mic? You want to use this one?
Thanks to all presenters. I'm Harry from Farm Access. So I have questions to Patrick. If I understand correctly, I think you have that form, which is a paper form, right? So can you say something on the challenge where patients lose the form and come and looking for? Is that a big problem? Because we have seen here in Zanzibar where they're using exercise book. That's one of the big problems. When they come again, they come with a new exercise book, then you lost all the data which you had before. And another question is to Joseph, who, you know, I admire your work and I've been looking for opportunity to work together. I hope it will happen next year. My question is, how do you see Dawa Mkononi in the future? Do you see it as a digital marketplace, so the likes of the Alibaba or AliExpress, or you see it as a digital store, like the likes of Amazon? Thank you.
Okay, so Patrick and Joseph, you'll note those questions. The second question, yes, please, madam.
Thank you very much. My name is Dr. Mary Rose Giatas and I work with Japaigo. So first of all, I really wanted to congratulate all the panelists. Excellent presentation. And I have 3 questions. So the first question, they're all very simple, so don't worry. So Rachel, I really wanted to learn. I know you have scaled up to 83 facilities. And I was wondering if you're planning to scale up into other regions in Tanzania. And in addition to that, I really wanted to learn on the TOT training. How many days does it take? And how many facilitators are engaged in that particular training? Because I feel like there's a window of opportunity to integrate with other programs. And then my second question goes to Faiza Abasi. Thank you very much. We are also working in Zanzibar. So I'm looking at an area where we can collaborate. We are supporting breast cancer program, and we are also doing NCD indirectly by measuring blood pressure to all our clients. So I feel like we can have an additional discussion together on how we can integrate. We leave you that piece of NCD because it's your space, and then we can concentrate with breast cancer screening. And we are screening a lot of women. So it's a big pull for you to integrate NCD. And my last question is for my fellow doctor. First of all, I admire you, your innovative strategy. Big congratulations. And I just wanted to learn the impact, 2 bullet points, not in the financial side, but the impact of your digital platform when health-related outcome is concerned. Thank you very much.
Okay, so let's get the panelists to respond because there's obviously at least 3 questions per person. So Joseph, do you want to start? Yeah?
Thanks a lot for the compliments. Maybe I'll start with Dr. Harry. The future of Damkononi is, the way we think it's not exactly a marketplace. We tried a marketplace approach back in the days and it didn't turn out very well because different suppliers have different quality of service and clients will always complain in case a delivery is delayed, and it's always going to be up to Damkononi. So we are thinking more of a tech data-enabled platform. We want to be a hub that accumulates as much data as possible. So whenever we scale up, we can also have a smooth transition on scaling. Supply chain is a very complicated business to handle, and it has been failing in Africa for quite a while because it has so many arms. There is logistics, there's the sales part, and so many others. So we want to stick to data, and we want to use advanced technology to make proper recommendations and predictions. So that would be my first response. And towards the impact side of things, thanks, Doc. And we think at Damkononi, our biggest impact is plain and simple. We're just improving the access to medicine. Behind that, there is so many complex sets of how we do it, but at the end of the day, that is our end goal. Our vision is to see even the most remote healthcare facility has adequate products in their stock and has access to financing. These are 2 major hindrances that all these facilities are facing. So in a nutshell, all we focus on is improved access, and how we do it is by making sure these people can get products and they can actually afford them. So I know it's a little bit vague, but but thanks, yeah.
Thank you. I think ours was mainly a recommendation from Dr. Mary Rose, which we really appreciate and we have taken it on board. But just to add on that, like this morning as we were driving to the conference, as we were in the car, we were also discussing about other NCDs and that cancer is becoming a major public health issue in Zanzibar. And we find like there is an opportunity to scale up and integrate other NCDs, including cancer. So I'm happy that you have also seen this, and we hope that we can have a future discussion on how best we can collaborate and integrate these services for the benefit of the community. Thank you.
Thank you so much for the question. Regarding the first question on the 83 facilities, as TDA, we have a number of programs. So for example, for NCD program, we've reached to all 26 regions where we have covered 710 health facilities. For the National Food Program, we have covered like all regional and zonal and national hospitals. But for the 83 facilities for national type 1 diabetes, those are major regional and district and hospitals. And there is a chance in the room for expansion as these new additional clinics were expanded after seeing that the number of type 1 patients that go to these lower facilities. For example, you can find the district hospitals with more than 15 patients they see per day. So we thought we could recruit any clinic that sees more than 15 patients, type 1 patients. So that's what has been our ways of adding more, expanding to more clinics. If there is any facility that sees more than 15 type 1 patients, then we provide training so they can have proper management. And so far, we've seen a number of improvement for that, because previously, in a year, we could have a total number of new patients, like 200. But since the training last year, in the past 6 months, we have reached 250 new cases. That means more expansion leads to more new cases coming up. On the issue of TOTs, we have training for 3 to 5 days, depending on which kind of training we are providing. So we have type 1 for foot, and the national, like the baseline, the basic training for all NCDs. It's like a comprehensive NCD training, whereby we incorporate practical sessions. So it takes 3 to 5 days. So we are open also to include other programs in it. And also all these programs, all this training, we've developed the training manuals who have been adopted and endorsed by Ministry of Health. So even if you need to conduct any NCD training, the Ministry of Health will offer you these training materials that we collaborated in developing them. Thank you.
So, Dr. Harry, I really appreciate the question, because this is something we are addressing on a nearly daily basis. Before I really answer, I just want to clarify, because you mentioned we have a paper-based solution. This is only one part of what Medificia does, and also only one part of the solution. We also have digital prototypes we are addressing, scheduling problems with, but you were referring to the PHMR card. So this is really a paper-based solution. And yes, one of the issues that we also learned very early on is that patients, as you said it, also here in Zanzibar, but also in all the other regions, or specifically in those regions that we are in, are also losing cards. So what we're doing is really, it requires a cultural and behavior change in terms of addressing, but not only the patient side who is losing the card, but what we need to do is involve the healthcare staff to highlight the importance of the data on those PHMR cards for them, to really teach and educate the patients about the importance of bringing this card, to really involve them in this process. As you're all quite aware of Ntua books, we do not want to be PHMR cards used like the same way. We do not want the doctor to fill in data and then to give it back to the patient without even having a real look at it. We want the healthcare staff to go through this card with the patient, highlight the importance of the data and of the learnings that the healthcare staff actually has from those cards, and really teach that towards the patient. So what we also observe is that there is regional differences. So as one example, in Gaeta, patients are already a little bit further in terms of keeping those cards and bringing them back to the facility compared to what Mwanza had in the beginning. So at the beginning, this was one of the issues we encountered, of course, but it really requires to involve the healthcare staff, to involve the doctors, to really make sure that they go through these cards with the patient together, involve the patient in their own journey, but at the same time highlight the importance of bringing those cards back. And this is something that seems to work if we can really make the patient understand how important it is to have that data, because there is not only the schedule for the patient on this card, there is really what did the healthcare staff provide over the last few visits, what medication has been prescribed, which doses. So there is so much information on this card that will be helpful for the healthcare staff, which is why they need to make the patient understand how important it is. Thank you.
Thank you very much. So I think we'll do one more round of questions, starting with the gentleman. Can we have the roaming mic, please? you have a question? Okay, so you will go second.
Thank you very much. My name is Swedi Yunus. I'm neither a medical expert nor a president with a small R and a big R. I'm just a curious individual. I have a small company. I deal with investment facilitation. I have two questions. One question for Joseph, Rachel, and Patrick. Rachel, Patrick, and Faiza. In terms of collaboration, all of you have indicated that you're collaborating with the government, Ministry of Health. So I just wanted you to evaluate 1 out of 10 in terms of your collaboration, your partnerships, 1 being the worst, hell, and 10 being the best. How is it going? And then second question for Joseph, in terms of innovation, we do know that our countries are struggling in terms of digitalization. So how easy or complex has it been for you in terms of bringing that idea, which I congratulate all of you for? Thank you.
Okay, there's one right across here. And then we'll have a third one right back there.
Thank you so much, and congratulations to all the panelists for a very insightful presentations. Though a little bit shocking, seeing how the problem is increasing. But the good news is that we are now here discussing the sustainable health system strengthening through integrated partnership. And congratulations to Dr. Joseph. You are an inspiration to many. So my question goes to Faiza and probably Patrick. Faiza presented to us a lot of community engagement in terms of addressing the NCD problem. But now we know that in most of African countries, including Tanzania, there is a small number of people who are having the national insurance for their medical service. In Tanzania, it's only 12% as we speak. So I'd like to know if there is any involvement of community pharmacists, including the pharmacist, pharmaceutical technician, and assistant, because it is normally not mentioned, but most of our people are going to the community pharmacies as their primary source of care. So how have we involved them in this project in terms of 1, capacity building and communication, working together with the primary health centers within the area, like the dispensary and the health centers, in order to make sure that every patient who enters a pharmacist and has the signs or symptoms or is in the risk group of NCD is not going out without being addressed. Thank you.
Okay, so one last one at the back.
Congratulations, the panelists. I'm Professor Stella Mpagama, working as an infectious disease specialist at Kibongoto Infectious Disease Hospital. So my question goes straight to Rachel. TDA has done a considerable work. Congratulations. I was interested to understand if you encountered any challenges when you were reaching to the TB or HIV clinics, because I've seen you have highlighted, but you didn't show data, the intersection of communicable and non-communicable disease. What were the challenges you encountered at the healthcare facilities?
Okay, so in the interest of time, I'll ask the panelists to answer the questions and then also give some form of parting shot or closing remark so that we end towards winding up. I think this time we'll have Patrick start so that Joseph can...
So, thank you for the questions. I will start with the very curious individual to my left. Thank you for the question, and it's a very interesting one, and it's not very easy to answer. I'm going to be very straight with you. I'm a very transparent individual, but it is not easy to be answered. So if you really want a rating right now, I would say 6 to 7. This is probably where I would situate my rating in this point. I'm happy to explain why. So Medificia is very fragmented, right? So we do have a lot of districts involved in our program. What we did recently in Gaeta is involve all the district medical officers, district pharmacists, district NCD coordinators. Bring everybody at one table is already very difficult. So this is already, the rating is already going down just because of the difficulty to reach each and every region. But this is more also due to the structure of the program because it is scattered in terms of facilities. We also want to reach districts in Gaeta, like facilities like Karumwa, that are really far off. So we need to bring those stakeholders as well into Gaeta district, into really like at one table to introduce them. Same thing applies for, going forward in terms of using, well, not using is maybe the wrong term, but having them as support us as multipliers, because sustainability is one of the biggest issues and the biggest challenges that we face by implementing programs. So what we need to do is involve district players, involve the regional medical officers, involve the RHMT teams to take responsibility, take ownership together with us, to really be able to have this program sustainable, to have a district pharmacist check up on the pharmacies that we are enrolling, besides only us doing supportive supervision, but them also being introduced to supportive supervision in the long term. So it is difficult to ask them to do all that besides their jobs. So this is why I can't give a 10, but I would say that most of the individuals we're actually encountering and most of the district or regional level players in the three regions that we are in, they're involved in a program. Specifically in Gaeta, we just had a meeting with all the relevant stakeholders, and they are motivated to help us as far as they can. Thank you. And then addressing the second question regarding making sure that people are able to receive medication, and also making sure that pharmacies are stocked. So our program, the Medificia program, is focusing on the main store and pharmacies. So we don't want to tackle issues at the dispensing unit or tackle issues at a community store. We really want to make sure that already, like before distributing medication into the wards, there is still a sufficient stock and there's still medication availability in the main pharmacy store to ensure that there will be no stockouts, to ensure at the same time that there will also be no expired medication. So this is the complexity between overstocking and understocking medication. So this is how we want to involve our processes and how we want to make sure that patients receive medication as soon as they go into those facilities and as soon as they go to the dispensing units, so that they also don't need to go to other facilities or other stores, or because this is an issue we learned early on, that sometimes a lot of facilities went to the facilities, a lot of patients went to the facilities, tried to get treatment, tried to get medication, but they just had none. So they need to take on the burden of transportation towards another facility and really try to avoid those kinds of things, that a patient receive treatment as needed, when needed, in a facility, is one of our goals, which we also try to work towards by improving, let's say, laying the groundwork of operational excellence in pharmacies to then carry on along the supply chain and avoid stockouts in the pharmacy main store already at a root cause. All right, thank you.
Thank you so much for your questions. To address the first question, on that scale, I'll give it an 8. And the reason why is because, as an organization, you also have your vision, your mission, and different ways that you want to approach something. So that may not be the same way as the government system works. So it's not all merry and gross all the time. It does not all happen overnight. It's a process on embedding your activities or embedding your vision together, and make sure you all come together to a conclusion on moving forward into a certain implementation of certain activity. So it's not all merry all the time. And but although the government is very supportive, there's that political will also, but it takes time. It takes time also. You want to see the changes happen as an organization, but it does not happen overnight. So it's a slowly change, adaptation. It takes very slow. So it's for us to see, and to sit down and watch and see how it's going to evolve. But it's an interesting thing to see that the government is also interested in NCDs now, and is taking the front seat in making sure that we are fighting against NCDs. And on the second question, as I mentioned about the integration, that will be our next steps. So what we did in the first step was just sensitizing the healthcare providers about the comorbidities, that these are all chronic illnesses, having HIV and any other NCDs. They're all chronic illnesses, and they're all the same patient. So we also wanted them to see the interaction between one having HIV and how they end up having other NCDs. For example, HIV patients can also have diabetes, can also have TB. So how to have that one-center approach. So that's what we have been doing so far. And in our next step, we hope that we are going to have integration in of these chronic illnesses. But one of the challenges that we've seen is that for HIV, as we all know, it's supported in terms of medications and accessibility of the services. But for NCDs, when you want to integrate them, people ask you, so how would the NCD patient get their medication? They're not free. It seems like they see there's a difficult for them to work together. It's difficult for them to take care of a patient at once, because patients can get medication for HIV, but when they go for NCD medication, they need to pay. They need to have money. They need to pay insurance for that. So that makes it difficult for them to adopt this integration. But the only opportunity that we see is that all these patients are being seen by the same healthcare providers. Even at the primary health center, we don't have a CTC doctor, we don't have an OPD doctor. It's all one unit. They're all being seen by the very same healthcare provider. So in the future, there will be that integration. Thank you so much.
Thank you. I'll start with the question from Swed on our collaboration with the government. Honestly, I would rank it around 90%. And why I would say this, the challenge itself and how these NCDs have been creating a burden to the financing of the healthcare system in Zanzibar. So it comes from the ownership of the problem from the government. So from the beginning, the government and the ministry saw the NCD is really a huge burden in Zanzibar, and they took a high ownership from beginning in designing this project. So we designed this hand in hand with the government from the initial stage to implementation to all that process. So it was easy working with the government. And one of the very successful stories that I'll mention is the high level involvement of the management of the Minister of Health throughout this intervention. The Minister of Health himself has been in the field several times to see how these patient groups are working at the community level. So you can see high-level commitment from the management of the Ministry of Health. Of course, in terms of challenges, there are some few challenges here and there, especially working with the team that also have so many other responsibilities. So sometimes you can have your timelines. You want to have this accomplished maybe by October, but they also have their other priorities. They also need to do some other intervention with other partners. But how can you address this? It's a joint planning ahead of time. So you know that in the next quarter, we are going to have 1, 2, 3. So you make sure that you engage them in advance. But I think what is really, really important is the ministry and the government to own themselves as a problem and see this solution as part of their intervention. So for us, it wasn't that hard to engage with the government. The other question on the insurance, I'd also like to say that the Revolutionary Government of Zanzibar, since its independence 60 years back, have been providing free healthcare services to all Zanzibaris. Until last year, when the social insurance law was enacted, and the implementation of this mandatory social insurance is by phases, and currently all formal sector from the public have been enrolled into the Zanzibar Health Service Fund. We call it Zanzibar Health Service Fund. And the next phase will be the enrollment of the informal sector. And for the group that will not be able to pay for the insurance, they will receive government subsidies through the Health Equity Fund. That's still under the process. So still, for those who will be able to pay, they will pay for the insurance. But for those who will not be able to pay, they will still be receiving insurance through the government support. So to answer your question on how we have involved the community pharmacists, so far we haven't done much engagement to the pharmacists, knowing that the community are still receiving these medications for free through the government funding. And we have been making sure that in these patient groups, there is constant availability of medication. And we have engaged the district health management team, the district pharmacist, central medical store, now called central medical store agents, to make sure that there is no any group that lacks medication. And at least for the last 6 months, the medication availability in the patient groups were about 99%. We still see like there is importance of including this into insurance package. And one of the things that we are going to do, PharmAccess in collaboration with Sanofi, we are going to do a costing study to see how these interventions cost in the patient groups, but also in the facility, so that to inform the Zanzibar Health Service Fund how these services can be incorporated in the Zanzibar Health Service Fund. Yeah, thank you.
Okay, thanks for your question. is lost. But thanks for the question. The adaptability of tech is still very nascent in our market, but it's growing. The internet penetration rate is growing. We know our median age in our market is still in the youth area, so a lot of people are using more of smartphones currently, but the culture of online buying and selling of goods is still on the lower side. Sometimes you visit a client and they will tell you, I have no internet, but they're on their Instagram page. And you're just wondering, how is that possible? But we are growing and we are getting there. We're a testimony that these things work. So I think it's only a matter of time. Within 5 to 10 years, we believe most of the people in these health facilities, the procurement teams, and everyone will be in the median age. So most people will be using tech. Yeah, thanks.
Excellent. Thank you very much. And I think it's time to bring this to a close. As you can hear, there's commotion in the adjacent room, time for lunch.